Welcome to iPEMS, a podcast series that teaches about medication safety in the emergency medical setting and provides you with strategies for quality improvement. I'm your host, Dr. Tiffani Johnson of the Emergency Medical Services for Children National Resource Center. Joining us today is Dr. Kathy Shaw. Dr. Shaw is the Chief of the Division of Emergency Medicine at the Children's Hospital of Philadelphia, and today she will be telling us about patient safety walk-rounds and some of the lessons that have been learned by implementing them at her institution. So can you just start off by explaining to us what exactly are patient safety walk-rounds?
Sure. Patient safety walk-rounds are a way of getting multiple people from multiple disciplines together to really examine what is the current culture or climate of safety on their unit, what are the issues that staff have, and it's a way of taking the leadership to the clinical area.
And who exactly participates in the unit walk-rounds?
So we usually have an attending physician and a senior nurse scheduled, but they're scheduled at all times of the day and night and weekends too. Once they're scheduled, that nurse and physician will go to the emergency department and try and gather other workers on the unit. So they will pull environmental service, child life, a clerk or secretarial staff, other nurses, residents that are all working on the unit. And they'll involve them in two things. One, they'll involve them in quality improvement activities that are very brief because we're all busy. But quick, bring them off the unit during their shift and start asking them questions. Usually the tools are chosen ahead of time, so you might have one on medication safety where you ask the resident working on the unit to look through a particular patient's their order set and see, are there any problems with the ordering, any errors, were there any medication administration issues, and interview them. We have one particular quality improvement one that we do at ours, which I think says it all, and that sounds simple, but hand washing. So you may choose a resident or a nurse just to stand there and watch and see who's washing their hands coming in and out of a room. At the same time, you get an environmental service worker to go around room to room and to check the alcohol supply and make sure that they're a quarter full or not. Usually you can't get either group to stop doing what they're doing because they're so fascinated. And not only are they involved in collecting the data, you change the way they look at things afterward. The environmental service worker that finds 2 rooms without hand wash and knows that they're part of a team to keep patients safe and becoming infected by providing that hand wash is going to check the hand wash every time they turn a room over. So we do some fun activities for about a half an hour. And then at the same time we gather more people and sit down and ask the classic patient safety questions that one asks on walk-rounds. And so there's things like, have you noticed any unsafe behaviors or systems on the unit that need to be fixed? Do you have a best practice to try and keep patients safe? Can you tell us about an event that did harm or almost harmed a patient that you were involved with? Not only does it gather information, it projects the message that you want to hear about errors or mistakes so that you can use that information to make improvements. They have to have a mechanism of reviewing the information that comes in and taking ownership for it and working on it. And they have to have a mechanism of getting back to the entire unit what they found, what they hear, what everybody is working on to improve it.
And can you give us some examples of medication safety issues that can be explored during patient safety walk-rounds?
So I'll give you a very concrete example. During walk-rounds, it was discovered on a medication QI that an error had been made in metoclopramide dosing. The child got too much metoclopramide, and when you could say, just write it off and say, oh, errors happen. Maybe they didn't look at the formulary. Instead, there was an in-depth interview of the resident, of the nurse that was involved, of the pharmacist that was involved, to find out, A, how did it happen, and what were the systems issues involved. Turned out there were multiple issues. One had to do with the nurse being notified by the pharmacist of the error speaking to the resident said very confidently that they used the computer order entry and it calculated things, so it must be right. The nurse stopped questioning because of the hierarchical issues of doctor versus nurse. The resident was right, it was calculated for them, and when we went back and looked, what happened was they put in the correct dose for a one-time dose. Then they went and it said that this was going to be given every 4 hours or every 6 hours. So the resident changed it to a one-time dose. As soon as they changed it from a one-time dose, the machine calculated a full daily dose. Now, that's a systems problem. If you had not gone through those different layers, so a group worked with the information department to fix the computer error, which by the way was happening for multiple medications and could have affected hundreds of patients. And because we interviewed, we looked in depth, it was fixed for hundreds.
And you've published a study back in December 2006 explaining some of the lessons that were learned by implementing this program at your institution. Can you tell us about some of the systems-based issues that have been identified as well as solutions for overcoming them?
Sure. I'll go back to the example of the hand washing. On the first rounds that we had an environmental service person go room to room, we found, my gosh, 25% of the rooms didn't have hand wash at all. Now again, we're changing a culture. Is it a blame? I can't believe they're not doing their job. Why aren't they filling these up? Go back, there's a policy and procedure, you should have been following it. No, we asked why. And it turns out that it is a flammable substance, that it was a mandate from the hospital that only one bottle could be stored on the unit at any one time because of this flammability. So when you have 70 rooms in a department, one bottle extra makes it almost impossible to do your job. So that's an example.
Well, it sounds like it's an excellent program. So what are some of the barriers to implementing a unit-based patient safety walk-arounds program in one's institution?
I think that in putting it together, you have to have people with the time and inclination to want to get together and meet and solve some of the problems. Find hours that people will commit to this. Make sure that nurses and physicians and non-clinical personnel are willing to work as a team. Some institutions are ready and some aren't for that. Probably the biggest barrier is the culture of blame instead of the culture of safety, so that people in general may be hesitant to report an error or a near miss because they may be blamed for it, or they don't want to tell their colleague that they're doing something wrong, or they even should have washed their hands because they don't want to appear confrontational.
In this podcast series, we're targeting trainees, medical students, residents, as well as fellows. Do you have any advice to residents who are becoming involved in patient safety activities?
You're the eyes and ears of an institution. You need to speak up. You need to put in events that have occurred, near misses, opinions, and as much as possible have a voice at the table.
And what advice would you have to offer pediatric emergency medicine fellowship trainees that are interested in becoming involved in patient safety issues?
Fellows can take, I think, more of an ownership role. You'll have more time than you do as a resident. You'll be focused, and fellows are focused in a particular clinical area. So they are able to, for the most part, tailor their schedule to be involved in whatever committee work is going to be done, and be able to run these unit-based walk-rounds at all hours of the day or night.
Well, thank you so much for joining us this afternoon, Dr. Shaw, and thank you to our audience for tuning into this episode of iPEMS. To learn more about patient safety issues in the emergency medical setting, specifically related to medication safety, please tune in to other episodes of the iPEMS series.